So yeah, essentially the interviews are sort of three stations, 10 minutes for each one. You may know this already, but essentially you've got a management station where you get given a question before the interview. It's usually about a month or so before the interview. You get given a question that you then have a couple of minutes to present an answer to, and then following your sort of answer, they'll ask you a few questions about what you've said. And then after this, they'll ask you a few questions about ethical situations. So a little bit like your SJT in med school, you kind of get asked a question similar to that, and then you just have to adapt around what you would do in that situation. So it's good to sort of prepare, reading what you did for the SJT as well, to kind of be able to give a constructive answer to those questions. And it's also worth sort of knowing a bit of knowledge about ethics and the different kind of things you could come across within working. So we'll touch on that a bit first, and then secondly, you've got your portfolio station. It's probably the easiest station. You simply just bring your portfolio to the interview, and they just look through it and check that you've got the correct evidence to what you said in your initial application. So all you have to do is just sit there whilst they look through it, and they may ask questions based on your evidence, and you don't really have to think very much about that. That's something that you have already prepared well in advance. So just look at the specifications from your application. In each area, they'll assign you points for your portfolio. You do get that before the interview as well, so that you can prepare your portfolio. Yeah, all you have to do really is prove that what you've said is true with certificates and letters and things like that. You can print off your foundation training portfolio as well, and that'll include kind of DOPs and things that will help you get points for clinical skills. And so, yeah, I mean, just fill your portfolio with whatever it says on there, but we'll touch on that a bit more as well. And then finally, you have your clinical scenario. That's probably seems the most challenging on paper, but again, it's just they're not really testing. They're testing that you have a basic clinical knowledge of surgical situations, but they're really testing your sort of safety, your diagnostic skills, and things like that. And essentially, you just talk through a clinical scenario, and I think they give you two scenarios. One is acute, and the other one will be around the perioperative period. So yeah, we'll talk a bit more about that as well. So you have the essentially, as I said, that's what I've already said, that this is what they give you before the interview to explain what you need to do in each station. But yeah, the management station, you've already prepared your presentation, and they give you a couple of minutes of questioning, and then you're given one scenario in which you just talk about what you would do in that scenario, and then they ask you a few questions afterwards to try and give you extra points. And then your clinical, you've got two scenarios. Again, it's the same sort of thing. You talk through, and then they give you questions to try and give you the extra points that you've missed out. So just general tips for the interview. I mean, it's just the same as any other interview. Make sure you dress smart. I saw a couple of people at my interview that weren't dressed smart. I thought it was a bit strange, man. Just make sure that happens. And then obviously you arrive in loads of time, because they do need to do loads of admin and stuff beforehand. I think if you arrive late, they don't actually let you do the interview. So yeah, that's another thing. I think they're done in London, but again, I don't know what's going to happen with COVID, if they're going to be face to face or not. But that's something that they'll sort of explain to you once they've arranged that. Yeah, I mean, there's lots of people who arrive to the interview with massive portfolios. Like, you kind of wonder how someone's got a portfolio that big at that stage of training. And usually it's because it's filled with stuff that's completely irrelevant and not going to get them any points. So don't really be put off by people with huge portfolios. You'll get the points. You can get the same number of points with less in it, because on some of the areas you're going to have things like, one publication is going to be more than a couple of audits that weren't published and things. So your portfolio can get more points even if it's not as big. That kind of puts some people off sometimes. You can revise for your interview as well. As people think with ethics and things, there's not much to revise, but there are a few things that you can sort of learn to help you with those stations. And I think the main thing is with your presentation, which is in the management section, the question that you have to answer, they're trying to see if you're kind of a good leader usually. I think last year the question was on leadership. And it kind of helps if you're speaking in a kind of clear and kind of confident way, because that then backs up what you're saying about, you're obviously going to say you're a good leader and things. So you need to kind of back that up with the way you sort of present yourself. So yeah, let's move on to kind of stations. First thing is management station. As I basically said, you can revise for it, although a lot of people think it's one of the easiest stations. They can trip you up with some sort of tricky questions. So in general, they tend to ask about the same sort of things every year. It's not particularly difficult. It's just once you've got like the main number of points, they try to trip you up with some tricky questions that are just gaining those extra marks to sort of stand you out from the other candidates. So essentially, I think the main ones they ask about are going to be consent for surgery, data protection, so things like confidentiality and things like that, and then they do sometimes ask about specific surgical things. They've been known to talk about statistics, although I think in recent years, hearing from people that not many people have had that one. And screening they've asked about before, so screening programs like colonoscopies and things like that. But again, that's I've not heard of that in recent years. The one I got was about consent. I think the patient had been marked on their right side and the consent form said the left side, and they asked me what I would do. So it was quite a straightforward situation. I think my first point was that obviously the surgery can't go ahead, so I made that very clear from the start. And then I went through and analysed, the different kind of ethical things surrounding that. And then afterwards, they asked me specifically about the WHO checklist and what I knew about that. And then they asked me about CPOD as well. So they asked me what is CPOD, why is it there and things, but we'll talk about that in a bit more as well. So I think usually they give you a scenario. They want you to talk and think about what you would do in that scenario, and then they'll ask more specific stuff after that, just to try and get you those extra marks. So I think a good place to start is the Good Medical Practice that's published by the GMC, and that kind of is what I read for my SJT as well. Kind of gives you an idea of what kind of things they're prioritizing when you're answering an ethical situation. I've written the 4 pillars of ethics, so it's good if you can kind of reference those in your answer. Although I think when you're under pressure in that situation, you might not remember to sort of to reference those. But I don't think I did in my interview, but it's good to kind of show that you know what they are. So autonomy being the patient's right to a choice, non-malfeasance being obviously doing no harm, beneficence obviously doing what's in the best interest of the patient, and then justice is what's in the best interest of the community as a whole. And they do like to pick situations where there's kind of confliction between those. So obviously in the Jehovah's Witness, the autonomy of the patient not wanting a blood transfusion, but that's going to go against your do no harm as well, as obviously if they need a blood transfusion, you might not be able to give that. So there's the kind of conflicting, and you can say, if you were given that scenario, you could say about how those two are conflicting. And yeah, I think it gives you kind of a base to weigh up your arguments. So yeah, I've got a situation here, as I said before, about consent. This one is a scenario that I think has come up before. So obviously you're the CT1, and you've been informed by your consultant that the next patient hasn't been consented and they need to be consented, but both the consultant and registrar are really busy, and you're already running late, and they've asked you to consent. So I don't know if anyone wants to sort of come in and say what they would do in this situation. If not, I'll just talk through it. Okay, so essentially, I think the first things first, you would say patient safety wise, you're not going to be able to consent them for this procedure if you don't have a knowledge of the procedure. So first things first in any ethical situation is I'm thinking patient safety is my top priority. So in this situation, that's the first thing I'm going to say is, well, it's the safest thing for the patient is that I'm not going to be able to consent them correctly. So they're not going to be able to have an informed decision about this procedure. So now you've got that out of the way and said that you're not going to consent them, you need to kind of then move on to what you would actually do. So I would try and sort of go out of my way to try and fix the situation. So first I'd gather more information, like ask the registrar or the consultant how long they're likely to be. Is there another registrar that knows the procedure that might be able to consent them? So try and gather more information about the situation, and the interviewers might give you a bit more information if you're lucky. And then from then you can go and say how you might solve the situation. And then think of the patient, so apologize to the patient for the delay as well, and just document everything. And those are the things they kind of like to hear, is that you're thinking about the patient, you're trying to solve the situation, but you're obviously not going to do anything dangerous, like incorrectly consenting someone. And that they do like you to just add on that you would document at the end as well. So another situation, again, so this one's more about confidentiality. So there's a sort of secretary viewing a CT scan of a relative, shows colorectal cancer, but the patient hasn't actually been informed of this yet. So it seems quite a tricky situation when you first get given it. But again, if you just stick to a structure, should be fine. So the first thing I always think of is patient safety, and then that will just like sort of roll off the tongue in the interview so that you have more time to think about the other steps. So you can say patient safety, obviously, patient's confidentiality has been broken. They're not aware of this diagnosis yet. So you need to kind of protect the confidentiality of the patient. So you should ask the secretary what they're doing first, and then try and sort of ask them politely to kind of stop looking at the scan, and that will kind of initially sort of try and protect their confidentiality. And then you could kind of gather more information, ask about a bit more about the situation. It might be that they have every right to be looking at the scan, although it doesn't sound like that in this situation. So just gather more information before you start accusing people of things. And then secondly, you try and sort of solve the situation. So in this thing, I would probably speak to a senior. I think escalation is another thing that they like to hear about as well in ethical situations. So so escalate to a senior, talk to the confidentiality department in the hospital, and then obviously you've got to think about the patient as well. So you may have to disclose to the patient what's happened, and you're gonna need a consultant to obviously break the bad news of the cancer as well. So that's why escalation is important. Obviously, you're going to structure your answer a bit better than I've sort of run through it. But yeah, this is the sort of structure that I tend to follow. So gathering more information. Obviously, you've got to be empathic when you're sort of giving your answer through. So you think about not only the patient, but also the person you're speaking to. You're not going to go in and sort of be accusing people of things. You have to kind of go about it in a empathetic way. So I think that's what they're trying to get from this situation is they're trying to see how would you deal with this conflict that's going to arise here. If you can kind of word your answer in a way that makes you come across as sort of uh, person that's going to be able to sort of deal with the situation, and that's going to be good. Obviously, escalate and then attempt to resolve. So, as I said, you may want to sort of interject to get them to stop looking at the scan, and then sort of talk to the patient with the consultant to kind of break the bad news, but also explain what's happened and that their confidentiality was broken. Then they may ask specific questions. So the Data Protection Act is kind of to do with storage of information, and they may ask, what does it actually entail? How long can you keep data and things like that? So it's worth just reading around. You can find kind of information on the internet about what questions have come up before, but it's worth reading around these specific questions just to find out. So that, I mean, if they asked you about that and you hadn't read about Data Protection Act, you'd be pretty stuck. But this is what give you the extra marks. So at the end of this sort of teaching session, I'll take your email addresses so I can send you a PDF file, and it's got basically all of the situations that can come up, and then that can kind of help you to determine what kind of things you should be reading before the interview. If you don't know anything about it, then you can kind of just waffle on a little bit, but yeah, obviously don't say anything that you don't know is true. But yeah, I mean, if they're asking you specific questions that are particularly hard, it's probably because you've already gained most of the marks from your answer anyway. Yeah, as I said, they asked me about the WHO checklist. I think I briefly read it before the interview, so I was kind of a little bit trying to just blag it basically. But yeah, if you know all the parts of the WHO checklist, then I mean, and you just reel them off, then obviously you'll get all of those marks. But yeah, I think the main thing is they want to know why it's there and the reason for it, and obviously it's to avoid never events. And then as soon as I said never events, they asked me what is a never event, so then I could talk a bit more about that, which I actually had read about and things. Um, so yeah, they're trying to give you the marks really, but that's another thing that's worth reading. CPOD as well. It's worth reading what each category is, why it's there. So CPOD's basically there to prevent. Well, there was a big sort of database that kind of found out that people doing emergency operations overnight, or even just elective operations, kind of basic things like hernias and stuff overnight, were having more complications. So CPOD came into place to prioritize surgery, but also to stop people doing out of hours operations that weren't particularly urgent. So you categorize operations based on their urgency, and then you can prioritize each operation separately. I think they asked me a few questions I didn't know the answer to as well about that, but yeah, I think CPOD's definitely something that's worth reading up about. They may give you operations and ask you, is this an immediate, urgent, or expedited operation? So yeah, as I said, it's sort of the main aim is just to improve safety really in operating in emergency situations. Yeah, they may ask you about ASA as well. I think that's come up before. Basically, they might give you a patient and say, what ASA grade are they? Obviously, the downside to ASA is that it doesn't take into account age, and also it doesn't really take into account acute illness either. And yeah, it's only systemic disease, so it's worth not just knowing what something is, but sort of the limitations as well. And I've just written here as well the Apache 2 and the APGAR scale, because if you're asked about a scale of, so for example, the pancreatitis severity scale and things like that, it's worth just knowing a couple more, because then that shows that you don't just know the main one that everyone uses, but you've also thought about, other scoring systems that other hospitals might use. But you don't actually have to know them in much detail. You just have to know the names, really. Or you don't even have to know them. It's just those extra bonus marks that you could get. They've asked about sterilization, so definitions on what sterilization is. I don't think that's come up in recent years, but it's still probably worth just knowing. And you don't need to know in much detail, but you can just know the definitions and then what agents are used for what situations. So heated tends to be used for kind of metallic things, surgical instruments. You've got dry and steam, so depending on whether it's a waterproof item or not. Chemicals tend to be used for like scopes, like endoscopes and things. They tend to use ethylene oxide. I think formaldehyde's not really used anymore. If it is, it's used for kind of mass processed stuff. And again, radiation, I think, is for mass processed stuff that's not that can't be sort of heated up and can't get wet, basically. But yeah, it's worth knowing about those things just in case they come up. Interpersonal skills. So they may ask about specific surgical situations. They may ask about things like that, but sometimes they do ask your generic sort of SJT questions. So this is the obvious one. This has definitely come up a couple of years ago, I think. Not everyone will get the same question either. So they'll have different questions on different days. But yeah, I mean, this is your basic SJT question, really. What do you do? So I use the same structure. So patient safety, obviously, I'm going to try and get this consultant to stop doing the afternoon ward round, and then maybe bring them aside and then gather more information. So ask them what's going on, try and find out, are they actually drunk, or find out a bit more. Probably escalate to a registrar, get them involved if I'm genuinely concerned, and then try and solve the situation. So probably once you've involved a registrar or another consultant, if there is one available, you can get the registrar to finish the round, or you can get another consultant to finish the round, and then you can try and sort of as a team with your seniors, kind of in a empathetic way, try and get the consultant to sort of go home, basically. Yeah, and then I would always document. I think in this situation, you're obviously not going to document in patient notes and things, but you just make a note of it somewhere that for your personal sort of records, so that if you're asked for a statement later on, you're able to sort of write in facts what actually happened instead of what you're trying to remember previously happened. So that's something they might like to hear as well. So yeah, that's just what I've gone through. Obviously, know your limits in this situation. A CT talking to a consultant about something so sort of serious is going to be a bit of a difficult situation. So you obviously need to get help, ideally another consultant, trying to resolve and escalate, etc. And yeah, I've written think of the consultant as well, because that shows empathy. You know, you're thinking, does this consultant maybe need help with their alcohol issues and things? So yeah, I think in any situation where you've got a colleague that's in trouble, or if someone's done something wrong, you need to also think about the person who's in the wrong, because that shows you thinking about all bases, basically, and it shows what kind of person you are rather than someone that just reads about ethics. Another similar situation that might come up, similar to your sort of SJT questions, is a cancelled theatre list. So, for example, the list is running over, or the consultant's sick or something, and they've had to cancel a whole list. So, top thing is safety. So, if the first thing I think of is, are there any patients that maybe have advanced cancers, or people that are semi-urgent that need their operation done as soon as possible? So then that would then move into resolution. So I try and find another theatre that perhaps has a bit of room on their list to add on more urgent cases. Or you can talk to the theatre managers, find out if there's a way of rearranging these patients so that they happen sooner. So yeah, it's really just kind of top priority safety, and then seeing how you would go about trying to solve a situation like this. And it's kind of your thought process, but also your kind of communication as well. Escalate, obviously, if you're the only one there, you may sort of start to deal with it on your own, but then if you're kind of getting out of your depth, then you'll probably want to escalate to a consultant or a registrar. They like to hear about the sort of hierarchy, as it were. So escalating to your registrar, and then if there's no registrar available, your consultant. And then obviously apologize to the patient. So always think about everyone involved who you need to speak to. Obviously, speaking to the patient, you need to apologize and explain what you're doing to sort of rectify it, and then document as well. Yeah, this top question is something that some people have had before, and I think they may have asked me this actually. Can't really remember, but it's a pretty difficult question if you think about it to answer on the spot. So um, I think when I was planning for my interview, I did think of an answer for this just in case they did ask it. It's worth just thinking about a difficult decision you had to make, and then you can talk through the steps of how you went about making the decision. And that kind of shows how you are sort of weighing up benefits and cons and things like that. The second one is about talking to your colleagues. So it's really trying to find out if, I mean, surgical training is quite difficult at times to get into theatre. It's difficult to make sure that you're not always on the ward and that you're not always on call and things like this. So they're trying to find out, are you going to be able to be flexible to kind of make sure you get good training? But yeah, I mean, you can still analyze these questions in the same way you do anything else. So the top one's kind of safety. If you're working loads of on calls, you're going to be tired and etc. And then you just go through the list and trying to sort of structure your answer in the same way that you structure all your answers. And yeah, the final one's another tricky question, I thought. Basically, if you don't really know much about the European Work Directive and restrictions and things, then that can be a pretty tricky answer. But it's not asking anything harder than the other questions. It's still just trying to get to the bottom of, are you going to be able to work and not burn out and get good training and make sure you're not always doing jobs that aren't going to aid your training. So as long as you've thought about it a bit before the interview, you should be fine. Sort of structuring those answers. Yeah, I've included about statistics. They have asked about it before, but yeah, it's just knowing kind of what things mean. So the difference between incidence and prevalence. Prevalence being all the cases in a moment in time, and incident being new cases over specific periods, so a year, for example. The difference between sensitivity, specificity, and things. It's just things that you can just learn before the interview, and just make sure you don't get them muddled up if they do ask about them. I think it's pretty unlikely that this comes up, but it's just in case it does, basically. It's written on other websites that I checked about the interview. It's been written as coming up before, but I haven't heard from anyone that's done it in recent years about this. Same with screening, really. Just know about it. Know these basically listed the things that a good screening program should have. I think PSA is a trick that they always try and get you out on the MRCS. So it might come up in interviews as well. But PSA is not an actual screening program. It's just something that people use to kind of quantify prostate cancer rather than actually find it, because it's not cost effective and things like this. So that's ethics. So that's the questions that you get asked after you've given your sort of presentation about leadership. So I don't know if anyone has any questions about that at all. Just write in the chat if you do. I'll just carry on. So yeah, the leadership question last year was this sort of reflect on your experience of leadership and how this is useful as a core trainee. So I don't know if they've actually released the question. It's usually released a bit before your interview, and basically just prepare like a 3-minute presentation, basically just to give. You don't have to do anything other than just speak for the 3 minutes. And I think the key thing is to speak sort of confidently, but also clearly, and you don't have to actually say very much, because if you're speaking slowly and clearly, then 3 minutes is no time at all. So what I did is I made 3 points. I went into this. I think this is off the BMJ or something. But I just Googled basically good leadership skills and qualities, and then I just picked three. So I picked three qualities, and then picked three examples of what I've done previously, and to kind of show those qualities. So, for example, if you were kind of the rep at med school, or your year rep at med school, or foundation year or something, you can say that you did that as your example, and then say pick a quality that you displayed during your time doing that. I picked three. I think I got to. I did think I thought I got to the end, but it's worth having an extra one in case, because they actually asked me after I'd done my presentation, "Oh, can you think of another quality that you have as a leader?" And I had luckily thought about it, but I think if you hadn't thought about it, then you could get a bit stuck by that. So always write a bit more than you have time, and then that way, if you run out of time, it's fine. But if you've got a bit of time left over, you've still got another thing to talk about. Make sure you put a little summary at the end. So if you know you're running out of time, just summarize everything you've said, and then that kind of it's like an advert for you, basically, in one sentence. And the key to this is practice. Like, just memorize it and just practice over and over again. And then when you say it, if you're saying like you're a good communicator and then you're kind of stumbling over your words and stuff, it's just going to look really bad. So if you practice and you're speaking clearly and confidently, then it just backs up everything you've said. So that's the kind of management station. Is your first 10 minutes. And then, so I think I found that station probably harder than the other stations, just because clinical scenarios are things you deal with every day, but these ethical situations, you just don't know what they want you to say. So I think the main thing to focus on is the clinical and management stations, but your management station, don't underestimate it, basically, is my advice. So for the clinical station, it's really simple. Basically, they just give you two scenarios. One's a relatively stable patient, usually a post-op patient, and then one's an emergency. I think I had a trauma. So there's a patient hit by a car or something like that come in, and then I just had to go through ABCDE, just the ATLS ABCDE, and it was really straightforward. And then I think I got to B, and then they said they basically told me that the patient had a tension pneumothorax. So I just talked through how I would treat that. So it wasn't particularly difficult, but I think to gain the extra marks, you just need to be really clear and sort of structured with your answer, and then think about how you would manage the patient after they've gone through the initial emergency. So will they need ITU, HDU, and things like that. And then the stable patient that I had was post-op fever. So I just listed off all my differentials for post-op fever based on how many days after the operation. So in the first sort of 24, 48 hours, it's usually a respiratory cause, so apoplecsis or developing pneumonia or something. And then after that, you have kind of wound infections, anastomosis, leaks, and things like that. So it depends on the operation. They really, really wanted me to focus on how I would gather information. So I'd say that I'd look at the op note. I'd say I'd look through all the notes and things, talk to the surgeon that did the operation, things like this. And I think it took me a while to say that I would look at the op note, and for some reason they seemed like they really wanted me to say that. So I think that's probably worth a mark on their mark scheme or something. So the op note can tell you whether it was a difficult operation, or if the anastomosis looked really kind of was really difficult deep in the pelvis or something, then you'd be thinking, is this maybe an anastomotic leak or something? And again, it's the same as always. Just keep your answers really confident, structured, and don't sort of say anything you're unsure about. Can everyone see the screen? I think Mohammed says he can't see the screen.
No, not anymore.
Oh, when did it disappear? There we go. Can you see it now?
Oh, yeah.
Okay. Has it been gone for ages, or is it a new thing?
I went away for a while, so I'll come back and it's gone.
Oh, okay. Okay, fine. Okay, I'll just carry on. So, yeah, I think the other thing that people sort of get worried about is if you get a specialty, like particularly ENT or something you haven't done before, then it's probably worth sort of just structuring your answer the same as you would with anything else. So A, B, C, D, E. And then if you don't know about the specialty, fine, you won't get those marks, but at least you'll get the marks about your structured approach to the patient. As long as you don't do anything that's going to sort of harm the patient, then you should be fine. So, I mean, these are the kind of situations that that have come up previously. So trauma is the one I said, post-op pyrexia, abdominal pain. Abdominal pain is quite a broad one. You just need to have a really long list of differentials and then kind of try and narrow them down with a structured approach to the patient. Complications, yeah. I think, yeah, we'll talk about a bit more about that in a moment. Urology and ENT and Peds and burns are the four areas that I thought if you haven't done that specialty, you might have a bit of difficulty answering those questions. So trauma, as long as you go through the ATLS, ABCD, you'll be fine. Basically, you get all the well, the majority of the marks. The key things I thought were important were when do you do a full body trauma CT? I would base that on the mechanism of injury. So if it's a very large car crash or something, I'd be thinking of doing a CT after my primary survey. The only situation you would sort of not do a CT is if they're very unstable and they've had a penetrating injury, a stab wound or something. In that case, you're probably going to go straight to either thoracotomy or laparotomy. So that's just one just to be aware of. You can find out all this information on the ATLS. I think the website's got a lot of information about it, but or if you can get your hands on the ATLS book, or if you've done the ATLS course, then you'll have the book, and that just gives you all the information about what to do with that. I think there's a bit in the PDF that I can send you later as well. When to do a C-spine, how to clear the C-spine. If you look into that, there are a few ways you can clear the C-spine, but it's pretty detailed, and I don't think you're going to have time in your station to sort of go into that into depth. So it's just worth just knowing about when you would clear the C-spine. GCS less than 8, obviously you need to intubate for those patients. So yeah, and then it's worth knowing a bit about the specific injury management. So obviously you're going to know the emergencies like tension pneumothorax and things, but if you have particularly orthopedic injuries, it's worth just knowing a little bit about how you do that. I actually didn't know anything about orthopedics really when I did my interview, and it didn't come up. But I think I would have just said something. If they ask you something you don't know the answer to, just say you would ask that specialty. So you'd call the orthopedic registrar, or you call your registrar to kind of help you with that. And that's the safest answer, really. They can't mark you down for being unsafe. Yeah, if you know GCS off by heart, that's good. They did ask me that as well. Just should be quite straightforward to get a mark if they do ask you about that. I've also included on the slide here the CT guidelines, CT head for children, and there's also CT head guidelines for adults as well. If you know roughly what those are, then that's a good thing to know as well. So fractures, yeah, I was saying about orthopedics. If you know a few of the sort of classifications of fractures, although again, I've not heard about this coming up in recent years, but it is in some of the things I've read about the core interviews. So probably worth knowing some of those as well. This is a question that was asked to someone I spoke to. How would you relocate a hip dislocation? Now, if I'd have got asked this question, I would have been pretty worried because I have no idea. But what they're asking really is, are you going to do it there and then in A&E yourself? And the answer is no, you're going to get a senior, because even if you do know how to relocate a hip, unless you're properly competent, which at CT1 you may not be initially, you just need to let your senior know, just in case something goes wrong, if you sort of catch a nerve in there or something like that. And non-accidental injury is another one they've asked about. If you suspect NAI at any point, then you just need to escalate again, and obviously think about the patient, and the mother's obviously going to be upset, or the parent or whoever's with them going to be upset if you start talking about social services and things. So just think about everyone involved and who you're going to speak to and how you're going to deal with potential conflicts. Pyrexia, as I said, having a list of differentials in your head is good. You can just go through them, and that helps you to sort of narrow down your investigations, narrow down what the answer is basically that they're trying to get at. Yeah, and then risk factors. So I'm not sure if they're asked me about this, but I think I've heard this from someone. They asked about the risk factors for complications in surgery. So you can talk about pre-operative risk factors, so age, pre-existing medical conditions, things like this, and then peri-operative, obviously a very difficult operation, a complex operation, and then post-operative would be how they recover, and whether they need antibiotics, infections, things like that. And yeah, I've written always remember the op note, just because I really think that they were trying to get me to say that I would read the op note. So I think it is something that's on their mark scheme. Yeah, I mean, you should know it's sepsis 6, but yeah, if you can say all of those, then it just shows that extra sort of knowledge that that you're able to deal with sepsis confidently. So for abdo pain, I think the main thing is just having a really long list of differentials. They may give you whereabouts the abdominal pain is, and then that can kind of narrow it down a little bit, and then you can just do your investigations to kind of rule out what it may or may not be. If you don't get to a differential by the end, it does badly. It just means that it wasn't sort of an obvious situation that they were trying to give you. They were trying to see how you would diagnose the patient. I think with my post-op pyrexia question that they asked me, I don't think I reached a diagnosis by the end, but they just told me, okay, this patient has atelectasis or whatever they had, and so they'll just tell you, and then they'll ask you how you would manage it, basically. So for any blood tests you request or any investigations you say you want, you need to kind of justify why. So you can say like, oh, I want FBCUs and use LFTs, but you need to justify each one, what you're looking for, why you're looking for it. And as long as you can do that, you'll be fine. But if you're just listing off investigations and you have no reasonings, then you're not going to get any marks for the investigations, I don't think. Don't forget urine dip. So I think the one that they like to trip people out with on the MRCS, but also from what I've heard in the interviews, they like kind of right flank pain, because that can be quite a few things. It could be pyelonephritis, could be ureteric stone, but I think the main one you need to rule out is AAA, and that's why urologists get CTs as opposed to ultrasounds. You know, when they've got pretty bad right flank pain, particularly in elderly people, you need to rule out a AAA, because that can present identically to ureteric stones, loin to groin pain. But yeah, don't forget the urine dip, because if you're going to take someone to theatre for appendicitis and they've got blood in their urine, it can still be appendicitis. But I think if I've seen blood in the urine, I'd want to rule out a ureteric stone. So urine dip's one that's easy to forget, but is very important. And yeah, obviously BTH-CG as well in women. This is just a kind of list of stations that what I've read on the online have said have come up before. Wound dehiscence apparently has come up as well. It's just probably worth knowing a little bit about that. Not all wound dehiscence is going to be, bowel coming out of the abdomen. It can be superficial, in which case you'd probably just make sure that any pus there is draining out properly, and then just allow it to heal on its own. If they do ask you about this, they will probably ask what you're going to do if there's bowel sort of hanging out of a laparotomy wound, and they're going to try and well, from what it says on what I read, they try to kind of get you to say that you push it back in, but that's not the right answer. You just make sure it's covered with something moist, and then call a senior, because they're definitely going to need to go back to theatre. Again, I've written about the risk factors as well. It's just, if you can say different risk factors for things happening, just structure them into pre, peri, and post, and that just gives you a bit of a structure to your answer. Jenkins rule, as you may know, is what you use to close the laparotomy wounds. It's essentially you close the wound with a non-absorbable monofilament suture, and you close it. The Jenkins rule is 1 centimeter apart, with full thickness. So you go through the whole sheath and make sure your sutures are 1 centimeter from the wound edge and then 1 centimeter apart from each other. So yeah, that's just another bit of knowledge that you can sort of use if they ask you about this. They may ask you what is Jenkins rule as well. So yeah, compartment syndrome has come up before. The questions they're asking you aren't sort of difficult scenarios. It's just making sure that you're safe and that you can identify an emergency. So I mean, this situation, by the time you've read the question, it's going to be compartment syndrome. So you just need to go through your ABCDE, and you can say, obviously, compartment syndrome, the main symptom you're going to get is pain that's out of proportion to the injury. And then you can say you may see paresthesia, pallor, pulselessness, pressure, paralysis, but the thing that's going to make you think compartment syndrome is going to be the amount of pain they're in, because the rest are all late features. So yeah, just go through your thorough examination, ABCDE, and then by the time you've finished that, you're going to be thinking compartment syndrome, so you're definitely going to escalate. They're going to need theatre, so you're going to prep them for theatre. Say you get a group and save, you tell the theatre coordinator, etc. Written handheld Doppler there. If there's one quickly available, that will help you to determine if there's pulse, if you can't actually palpate it yourself. So that's something you can think about as well. So your answers are just going to be the same for everything. ABCDE, be really detailed, think of every investigation possible, try to rule out all the different causes that are in your head, and narrow it down to what they're trying to get you to say is the actual diagnosis. The confusion is a big one because they think surgeons don't know anything about medicine, so it's good to know a bit about medical causes for confusion as well. So urology is, if you haven't done a urology job, you might find quite tricky, but the main things are going to be just painless hematuria will be obviously your top priorities. Differential is going to be bladder cancer, but there are other causes, so just have a list of differentials. Loin pain, as I said, top thing you want to rule out is AAA, because that's going to be immediately life-threatening. But then your second differential, most common, is going to be either UTI or ureteric stone. Testicular pain, first thing, torsion is the emergency there, so that's the first thing you're going to think of. And then urinary retention is a common thing that urologists see. I don't know if that's actually come up in the interview before. And Gleason score is a way of saying sort of staging prostate cancer. ENT, I think the main thing with ENT is going to be your emergencies. But they may ask you, how would you examine a neck lump? So epistaxis, the first things first is the emergency situation, stopping the bleeding. So just put pressure on the soft part, as I'm sure you learned at med school, and then stabilize the patient, fluids, etc. Packing, they tend to pack the epistaxis if it's persistently bleeding after the first aid measures. And if you pack an epistaxis, then you usually have to admit them to the ward as well. Yeah, I don't think it's anything different from med school, really. If they ask you a very specific question on ENT or something that you don't know the answer to, don't panic. It's just that extra mark to sort of they always ask just sort of one thing that's extra hard just to kind of throw you off, but don't worry about it. Just say either you don't know or you'd ask a senior. Peds, again, the year I took it, no one got asked about peds, but it has come up according to some of the things I've read. But again, you just need to know maybe a little bit more than med school, maybe a basic sort of your start of MRCS revision kind of knowledge of pediatric emergencies and things. Burns, again, it's a kind of low-level MRCS knowledge of burns would help you there. But again, it's just ABCDE. If you don't know the equation on the day, if you forget it or anything, it's not the end of the world. You just say you would use the standard kind of rule of nines to estimate the percentage burns, and then use that to give fluid. They may then give you the kind of amount of fluid that needed in 24 hours, and then ask you if you know to kind of give half in the first 8 hours. I don't think you need a really in-depth detail about burns and stuff. If you get asked about it, it's just to kind of throw you off again. If you know it, great, but if you don't, it's not. Don't let it ruin the rest of your interview. So yeah, finally, is the portfolio station. You really don't have to do anything on the day for the portfolio station. You just have to sit there, and they'll ask you about what is this, what does this show, etc. I think the main thing about the portfolio is to structure it in the exact order that they give you on the mark sheet, and that just makes it way easier for them to mark off all your headings. I had a summary page at the start of each of the headings that they give you, just to say what score I'd given myself and the evidence that I've supplied, and then that just made it easier for them as well. I've said don't pollute your portfolio with evidence you're not going to get marks for. So you'll get the mark scheme. It will tell you exactly what you get marks for. I think it's available now. It's been the same for the last few years, so I doubt they'll change it. But if you've got something that you want to kind of show off, but you're not going to get marks for, I would put it in the section that's about your commitment to specialty, because that is such a vague kind of section. If you've got loads of kind of stuff you've done that's not getting marks in other sections, then it kind of adds on. They gave me points for my e-log book. So if you've assisted in any operations, you could put your e-log book summary page in there. And that you get a mark for commitment to specialty and kind of clinical skills in there. Include all your DOPS from your F1, F2 years, and you get marks for your clinical skills section as well. With audits, I made a little diagram, as you can see on the slide, just saying how I've completed the cycle, and just to say that I was involved in every step, because that's something they want to hear about as well. So include all your audits kind of slides or whatever you use to present it, or all the data or anything that you have to prove that you actually did the audit. And then at the front of each kind of little audit that you've done, you can put that diagram just to say that you've done it in each stage, and that it's a complete cycle, because they want to see that you've done a complete cycle, really, for it to be a proper, what they call it, a QUIP project. So you need to make sure that you've done a proper quip, which is going to be 2 cycles, so a full cycle, and then you've shown that you've actually implemented change. So does anyone have any questions about the interview at all? Obviously, everything I've said is kind of what I've read online and also my experience of the interview. So it's not necessarily going to be what you'll get in the interview. But yeah. Nathan, did you have a question?
Nathan's got his hand up.
Yeah. Okay, well, if you fill out this
I have a question, sorry.
Yeah, go ahead. Yeah.
Hi, firstly, thanks for the lecture. Very useful, very insightful. The first mini question is, I hope, because I missed part of it, I don't know what happened along the way. So I think it's all being recorded from your side, is that correct?
Yeah.
Lovely, thank you. So secondly, in terms of the interview itself, I am doing a trust grade job as a surgical F2, and as long as you provided all the evidence, do they ask you specifically why you've chosen such a route or not, or it doesn't really matter?
Yeah, I think I'm not too sure about that because I went straight through training, but I don't think there's any situation in the actual portfolio station where they're going to specifically ask you questions like that. I think it's going to be because you're not going to get marks for those things. They can only give you marks for what's on the sheet that they give you to structure your portfolio. So as long as you've shown that you've done all the audits and things, I don't think it's going to disadvantage you for taking a year to do a trust grade or whatever you did. So I don't think you're going to be disadvantaged by that at all, as long as you can just justify all of the marks that they've given you. I don't think there's anything on that mark scheme that talks about that at all. If you're eligible for the job, it should be fine, I think.
Fine, thank you very much.
That's right. So yeah, if you guys fill out the this feedback, then at the end it asks you for your email. Then I can email you the stuff that I use to kind of prepare for mine.
Hello?
Hi.
Oh, hiya. Do you think, so I'm planning on an F3 and an F4, or potentially an F4. Does that look bad in terms of interview if you've taken an F3? Or do they prefer people that have gone straight from F1 to F2?
So yeah, I mean, again, I don't know exactly what they have on their mark sheet, but as far as I'm aware, it isn't anything that's specifically going to give you all as long as you meet the eligibility criteria, you shouldn't be disadvantaged in any way. If anything, if you had more time to prepare for your portfolio, you may get more marks on your portfolio. So I don't think you're going to be disadvantaged in any way, but just be careful because on the person specifications for the job, it does say that if you've more than a certain amount of time of surgical experience, then you're not eligible for the job.
If you've had not enough time or too much time?
Too much time, yeah. I think if you've had more than like 16 months or something outside of your F2 jobs, then I think you're not eligible, but just double check that because I'm not sure. Yeah.
So therefore, I wouldn't be able to take an F4 then, no?
Well, you can, just not in a surgical job. But if you double check this, the person's specifications, because that will tell you exactly what you need to do.
Okay. And then a final question. Do you think it's, because I'm planning on doing an F3 regardless, do you think it's worth applying this year as a practice, even if my portfolio is incomplete?
Yeah, it's definitely worth doing. That was my plan initially, was to do an F3. So I used this as a practice, and then I still got a job despite my portfolio not being as good as I thought it needed to be to get a job. So if you're planning to do an F3, I would still apply, because you never know, you might get the job that you want, and then that might change you may just get it anyway, and then in that case you kind of going straight through to the job that you wanted.
After you may not know this, but if I then get the job, almost like accidentally, would I still be allowed to take a year out and then reapply, or would they frown upon it?
I'm not too sure about that, but it would be like you'd have to kind of talk to them about that basically afterwards. But I think even if you're really not intending to take any job that you get, it's still definitely worth applying to run through the interview and how it works, and then you also get the benefit of knowing what kind of questions they ask as well. So I think it's worth kind of practicing, definitely. They're not going to mark you down for doing the interview and then rejecting the job.